Hello everyone. Today we will see ovarian common cystic lesions. As we know all, these are very common and these are very commonly found on ultrasound in day-to-day practice. In most of the cases we can confidently diagnose them on ultrasound. Few times we may have to do ultrasound follow-up and in few we may have to do further evaluation by MRI or CT. So we will see these how to do. We will see in this PPT physiological cysts like follicle cyst, corpus luteal cyst. Then cysts which are commonly can be diagnosed on ultrasound like hemorrhagic cyst, endometrioma and dermoid cyst. Then again extravariant benign cysts which can be diagnosed on ultrasound are simple cyst, peritoneal inclusion cyst and hydrosalpinx. Then ovarian cystic lesions can range from at one end to very simple benign appearance cyst to a malignant looking more complex cyst showing thick septal solid component. We will see this spectrum and what are the worrisome features like multilocularity and solid component and thick septi and vascularity. We will see all these in detail. Then these are the two common physiological normal cysts which can occur in ovary. These are follicle cyst and corpus luteal cyst. Follicle cyst, this will appear, both the cyst you remember they will be somewhere around 3 centimeter, and this follicle cyst will show thin wall, unilocular, no internal flow and no internal septi or echoes. It will be a simple cyst around 3 cm. Corpus luteal cyst may show thick wall, cannulated border inside and peripheral increased vascularity. This can be called fire of ring sign. Sometimes it will appear solid on grayscale, but on color Doppler it will show peripheral vascularity. In these two types, we don't have to do any follow-up. Then we will see three common cystic lesions which can be diagnosed on ultrasound. These are hemorrhagic cyst, then dermoid cyst, and endometrioma. Hemorrhagic cyst can appear as a cyst with internal thin multiple septi, which will give reticular appearance or fishnet appearance. Then sometime it will show a clot, peripheral clot, and it won't show any vascularity on color Doppler, and it will show sharp concave margins. Then dermoid cyst, it will appear as a cystic lesion. Cystic component will show thin hyperechoic lines or dots. It will have central or somewhat peripheral echo-reflective focus, but there won't be any vascularity in this cystic lesion. Rare but typical again can be this type of pattern like multiple echogenic spherical ball-like structures inside the cystic component. Then endometrioma, it will show internal homogeneous ground glass echoes, low-level echoes, and it can show punctate echogenic foci in the wall. So these three patterns can be confidently diagnosed on ultrasound, and we can label them hemorrhagic cyst, dermoid cyst, endometrioma. Then few typical benign appearing or benign extravariant cysts, cystic lesions are para-ovarian cyst. It is a simple cyst separate from the ovary. Then this is a peritoneal inclusion cyst in which the ovary is embedded in the center and is surrounded by the fluid or the cystic component, and it will show thin septi. The pathology is like that. It will be most of the time post-operative sequence, and because of post-operative adhesions, the fluid secreted by the ovary won't be absorbed by the peritoneum and it's getting accumulated around this ovary, and septic can form in this cystic component. Typical ultrasound or CTMR feature is that the cystic component will conform to the shape of the adjacent organs like pelvic side wall or the adjacent uterus or bowel loops. It will not cause any mass effect or it will not have a spherical shape. It will take the shape of the adjacent organs. Then hydrosalpinx, this is extra ovarian elongated tubular cystic lesion. It will show incomplete septi, which are nothing but folds, and it can also show echogenic endosalpingeal folds. So we saw uh, typical ovarian endometrioma dermoid cyst. Then we saw typical extra ovarian simple cyst, hydrosalpinx, and peritoneal inclusion cyst. Now we will see ovarian cystic lesions, which can range from simple cyst to more and more complex ovarian cystic lesion, which will indicate more towards malignancy. This image show a unilocular simple cyst with no solid component, no septi, no vascularity, and imperceptible wall, no echoes always as well. This is showing focal wall protrusion less than 3 mm. This is showing few locules. This is also showing few locules. But these locules are showing smooth border. Here the internal locules or septi are showing appearing irregular. Here multiple locules are there, but there is more increased vascularity in this wall of the septa. So this is the most benign. As we go more towards the spectrum, the complexity and the chance of malignancy will go on increasing. Again, if the protrusion is more than 3 mm, we call them as a papillary projections. More the papillary projections like this, more the chance of malignancy. This is a solid component showing vascularity. This is a multilocular lesion showing solid component as well. So more the locules, more the solid component, more the vascularity, more the complexity, and more the chance of this lesion being a malignant lesion. This is a mixed solid cystic lesion with a solid component showing vascularity, which will be at the end of the spectrum and which will indicate malignancy unless proved otherwise. So these are the worrisome features like multilocularity, thickened wall or thickened septi, irregular also. Then more the papillary projections, more the chance of malignancy. Then solid component with vascularity will indicate more towards malignancy. Vascularity also will affect the chance of being the lesion malignant. More the vascularity in the solid component or the septi, more towards the complexity. Size also matters. And if ascites is there, which is not explained by the general condition, and if we can demonstrate peritoneal deposits on ultrasound, then obviously it is going towards the malignancy. Age of the patient again matter. So we will see how to follow the common cystic lesions which we diagnosed, which we can diagnose on ultrasound, like hemorrhagic cyst. This is hemorrhagic cyst showing reticular appearance, fishnet appearance, thin internal septi, no vascularity. Remember, if it is less than 5 centimeter, no follow-up is required. If it is between 5 to 10, between 5 to 10, we have to do 2-month follow-up. But if it is more than 10 centimeter, which is rare, but in that case, we have to do MRI for further characterization because we cannot see the whole volume of the cyst. So after MRI, if there is no suspicion, then we can do 6-month regular follow-up with ultrasound. Then next is dermoid cyst. This is a dermoid cyst with a cystic component showing echogenic lines, dots, and echo-reflective focus. Then many times it can be removed by the gynecologist because of its symptom and because of the risk of the ovarian torsion as well. Then also for patient anxiety, it can be removed. So if it is not removed, then we can do USG every 12-month follow. And if they are not showing any typical features like this on ultrasound, then fat density in these lesions can be diagnostic and which can be picked up on CT and MRI, really sensitive. So if we are not confident on ultrasound, we can do CT MRI. But then endometrioma is a typical endometrioma showing homogeneous low-level internal echoes. Here If the patient is in premenopausal state and if the lesion is less than 10 centimeter and if it is not removed again for any symptomatic region, then we can do every 12-month follow. And if it is more than 10 centimeter, again we cannot see the entire volume on ultrasound, then we should do MRI to confirm the benign nature. And after confirmation, then we can do 12-month follow if there are no suspicious findings. Then in postmenopausal, even if it is less than 10 centimeter or more than 10 centimeter, we have to do MRI for confirmation of benign nature and if not suspicious and not removed again for any symptomatic reason, we have to do 12-month regular USG follow. So these are the typical extra-ovarian cystic lesion we saw. Typical para-ovarian simple cyst, peritoneal inclusion cyst, hydrosalpinx. Imaging wise, there is no need of any follow-up, but if they are symptomatic, then gynecologist will treat accordingly. So remember, MRI is better for characterization of the lesion, and CT is useful to stage the lesion if lesion turn out to be malignancy. So to conclude, functional cyst like follicle cyst and corpus luteal cyst, which will have size around 3 centimeter. In that cases, we don't have to do any follow-up. And typical ovarian lesions like hemorrhagic cyst, endometrioma, dermoid cyst, we can diagnose on ultrasound, and we saw how to monitor them depending upon their size and the patient's age. Then we saw the ovarian lesions ranging from simplicity to complexity, which will depend upon the locularity, wall and septal thickening, their irregularity and solid component and the vascularity within the solid component and the septal thickening, more the papillary projections, more the complexity. Then we saw UAG is modality to follow. MRI is better for characterization of lesion. But on ultrasound, if the lesion is very suspicious, then we can directly go to the CT for staging. Please remember, we have not covered ORADs in detail. And also we have not covered the solid lesions, purely solid lesions of the ovary like thicoma. Thank you for patient listening. Thank you.